So thank you very much first of all, for your kind introduction. So it's really my honor to be here to share about this topic. And yeah, in my medical school years, actually, Professor Fogg is the one who passed my clinical exam of my pediatric rotation. So it's really honored to be here to share a talk today. So today, I'm going to share with all of you about anti-epileptic drug level monitoring. So I have added another title here, therapeutic drug monitoring of anti-epileptic drug, because I will use the short form TDM and AED in many of my slides. And as Dr. Wood just now mentioned, actually now the ILAE would use the anti-seizure medication as a term to describe the anti-epileptic drug, but I just fixed to the original titles, forgive me. So I will just use the term AED here. So here is the outline of my talk. So first, I will introduce about the concept of AED's reference range and therapeutic range. And then I'll give a quick revision of some basic drug pharmacokinetics, because that is really important for us to understand this topic. And then I'll talk about the sampling time. And then I'll talk about total and free drug concentration. And then we'll look into the impact of therapeutic drug monitoring on clinical outcome. And then the indication for therapeutic drug monitoring of AED. And we'll share some characteristics of commonly used AED. And finally, I will conclude my talk by talking about the 10 golden rules concerning the therapeutic monitoring of anti-epileptic drugs. So first, what is our AED reference range? So when we look at the lab result of the anti-epileptic drug level, so we'll see a blanket, right? And there is some number there. So what is that number actually means? So it is actually just a range of drug concentration quoted by the laboratory. For the lower limit means below which a therapeutic response is unlikely, and for the upper limit means above which toxicity is relatively likely to occur. But we have to know that this is just a statistical estimate of concentration interval at which majority of patients showed an optimal response in a variable number of studies. And these numbers are actually based on early studies conducted in severe epilepsy with frequent seizures, and patients with easy to treat epilepsy has been excluded in those studies. So a threshold concentration at which no patient will show a therapeutic effect, although present, is very difficult to define. And the upper limit of drug concentration also varies in different patients. That means some patients may experience toxic symptoms at a lower drug concentration, and some may tolerate and require a drug concentration that is, we call it a normally toxic range. So in another word, the reference range is actually not the therapeutic range. That means a number of patients actually tolerate a lower or a higher anti-epileptic drug level outside the reference range. So here comes to the idea of individual therapeutic concentration. And this is the measurement of drug level once a patient has been stabilized on one's optimal regimen. So it's preferably measured on at least 2 separate occasions, for example, 2 to 4 months apart at the steady state. So for steady state, I will talk about it in details in my next slide. And for patients with infrequent seizures before starting treatment, this can only be measured after a long period of observation. And this individual therapeutic concentration may not be able to determine if the patient becomes free from seizures and adverse effects at initial prescribed dosage. But this is believed to be a very useful guide for clinical management for an individual patient. So next part, we'll go to the basic pharmacokinetics. So first, I'll talk about steady state. So what is the steady state? This is after being given repeatedly or continuously. The steady state is the time during which the concentration of the drug in the body stays consistent. That means the quantity of drug eliminated equals to the quantity of drug that reached the systemic circulation. So from the diagram here, you can see after 4 to 5 half-life, after starting the treatment or dose change, then you see that the drug concentration will become constant. So here is the steady state. I think the key word is 4 to 5 half-lives. And here the diagram shows the plasma concentration over time. And you can see that for drug with a shorter half-life, the time to go to the steady state is shorter. For drug with shorter half-life, it will take a longer time to reach the steady state. And the dotted line will show the effect of the loading dose. And in this table, it shows the pharmacokinetic parameters and serum reference ranges for various AED in adults. So I have highlighted phenobarbital and phenoltoin here because these two drugs has a long half-life compared to the others. And it can, in here, you can see that for drug with long half-life, they would take a longer time to reach the steady state. And another keyword I want to point out here is the word adults. I make it capital letter because these numbers is only for adults. The reason why, because the AED half-life is actually different in children and adult. So in here, you can see that the difference can be quite big. And usually, generally, the half-life in children is shorter. So next, actually, what is the half-life of a drug? It's an estimate of time it takes for the concentration of drug in the body to be reduced by 50% and demonstrated in the two graphs here. And then I will move on to talk about first order and zero order kinetics. So for first order kinetics, it means a constant proportion of the drug is eliminated per unit time. And for zero order kinetics, mean a constant amount of drug is eliminated per unit time. That means at higher drug concentration, the same amount of drug is being eliminated. The elimination half-life is dependent on the drug concentration. So the larger the drug concentration, the larger the drug concentration, the longer the elimination half-life. So in this this graph here, you can see that if it follows the first order kinetic of elimination, the drug level will fall. The half-life will be constant, and the drug level will fall following the first order kinetics. If it's zero order kinetics, you see that at high concentration, the half-life is very long compared to low concentration. And then here comes to linear and non-linear pharmacokinetics. So for linear pharmacokinetics, it's a dose-independent pharmacokinetics. That means absorption, distribution, metabolism, and excretion of the drug all follow the first-order kinetics. And for non-linear pharmacokinetics, it's a dose-dependent pharmacokinetics. That means at least one of the ADME processes does not follow the first-order kinetics and become saturable. We have to understand the properties of the anti-epileptic drug we use so that we understand about this. And actually, be very careful for those drugs that have a non-linear pharmacokinetics. Some examples are elimination process of phenoltoin, autoinduction of carbamazepine, and saturable protein binding of valproate. And the diagram on the left actually demonstrate that and the rate, the elimination rate increase linearly. That means follow the first order when the drug is given at the lower dose, and then it become a mixed order rate at intermediate dose and become a zero order rate at higher dose. That means when they reach the Vmax, that means the maximum elimination rate, then it will become a constant rate elimination. What is the problem is that initially it's follow the first order, but when it becomes a zero order, a small increase in dose would cause a major increase in drug concentration. And this is very important because if the drug have a non-linear pharmacokinetics, we have to be very careful when you are using a high dose. So next, I will proceed to the collection time. So when should we collect the blood for therapeutic drug monitoring? So the first keyword is steady state. So if you remember, I tell you the keyword is 4 to 5 half-lives. So we need to understand the properties of the drug, and the sampling should be done at the steady state. That means after 4 to 5 half-life of that drug. If the sampling is taken before reaching the steady state concentration at that dose will be underestimated and may lead to a higher than necessary dosage adjustment. And one special drug I want to point out is carbamazepine because it undergoes auto-induction. That means the clearance will increase by threefold within 30 days after exposure to the drug. So a sampling taken before auto-induction is completed will result in an overestimation of the steady-state concentration. And here is the laboratory user guide of Princess Margaret Hospital. So I want to show you the suggestion from our lab. For carbamazepine, it will suggest the collection time to be immediately before the next dose for carbamazepine, as well as valproate. But for phenobarbital and phenyltoin, it actually suggests a random but consistent sampling time instead. So why some of the drugs they suggest random sampling, but some they suggest trough level? Is actually related to the half-life of the drug again. So for AED with a long half-life, fluctuation in the serum drug concentration during a dosing interval would be negligible, and sampling can be collected at any time. So say phenobarbital and phenyltoin. But for most anti-epileptic drug with short or relatively short half-life, it is important to standardize the sampling time in relation to the dose, like carbamazepine, valproate, or lamotrigine. Unless toxicity is suspected, the ideal blood sampling time would be immediately before the next scheduled dose. That means a trough level, and preferably in the morning after an overnight fast. So in these two diagrams, you can see the concentration of drug. For a drug with short half-life, it will fluctuate a lot. And for those with long half-life, it will be remain quite static. So the basic principle for blood collection would be two keywords: trough level and steady state. So next, I'll talk about total and free fraction of anti-epileptic drug. So some anti-epileptic drugs are largely bound to protein, but only the free drug, that's the unbound drug, is the active component of AED. But total serum level reflect both the bound and unbound AED, and its measurement is less expensive and less time consuming compared to measurement of the unbound fraction. So normally, routine monitoring of unbound AED is not necessary. However, some of the drugs are extensively bound, such as phenyltoin and valproate. They are 90% bound to protein. In that case, the measurement of unbound level may be useful and can reflect the pharmacologically active concentration with greater accuracy than the total drug level, particularly on conditions like renal disease, liver disease, hypoalbuminemia, where the protein binding of AED may be affected and the level of active components of AED may change significantly. Unfortunately, I think this unbound fraction of AED is not available in most of the laboratory. So what can we do? Actually, there are some formula available for us to calculate the corrected drug level, just as phenyltoin. So in case of hypoalbuminemia, we can refer to those formula to calculate the corrected phenyltoin level for both normal and impaired renal function. So next, I will talk about the impact of therapeutic drug monitoring on clinical outcomes. So are there any evidence proving the usefulness of this, where if we spend so much money and time doing this? And in year 2000, Lipotin and actually published multi-center randomized control trial on clinical impact of therapeutic drug monitoring in patients with newly diagnosed epilepsy. So at that time, 180 patients were included, and they were started on treatment with carbamazepine, valproate, phenyltoin, phenobarbital, or primidone, and they were randomly allocated into two groups. So one group, the dosage was adjusted to achieve the serum AED concentration within the target range, while the other group dosage was adjusted just based on the clinical grounds. And what they found out is that there were no significant difference between the two groups, talking about achieving a 12-month remission, or patient remaining seizure-free since initiation of treatment, or the time to first seizure, or the 12-month remission, even the frequency of adverse effect. So they conclude that early implementation of serum AED level monitoring did not actually improve the overall therapeutic outcome, and the majority of patients could be satisfactorily treated with adjusting dose on clinical grounds. That they also add a special remarks in the conclusion that only a small minority of patients were treated with phenoltoin in this study, and they believe that the drug for which serum concentration measurement are most likely to be useful. How about the newer anti-epileptic drug? So there's another randomized control trial published in year 2020, and is a randomized control trial including a patient in two groups. One group is they call it the systemic group, and the other group they call it the rescue TDM group. And they are adults with epilepsy treated by lamotrigine, levetiracetam, oscarbazepine, topiramate, brivaracetam, solizumab, or pregabalin. And in the systemic group, the AED plasma level were available at appointment, whereas in the rescue group, the level will only know if the study endpoint were reached. That means inefficacy or adverse events. And the primary outcome was the proportion of participants followed 1 year without reaching one of the predefined endpoints. And the conclusion is still there's no difference in terms of the outcome regarding treatment efficacy or tolerability. So this study actually provides a Class A evidence that systemic drug level monitoring of newer generation AED also does not bring any tangible benefits in the management of patients with epilepsy. Oh, so why are we still doing the therapeutic drug monitoring, right? Of course, it has its use, but it's not doing it randomly. It's not doing it routinely. We need to do it in special situation and with the indication. So we move on to the next part. What are the indications for therapeutic drug monitoring of anti-epileptic drug? So number one is after initiation of the treatment or after dose adjustment, is when the clinicians want to aim at a pre-selected target concentration for the individual patient, then we can do it. For the second indication is we want to establish the individual therapeutic concentration. I have introduced this idea in very early of my talk. So they believe that is a useful point of reference to guide the treatment if there's a change in response occur. So number three is to determine the magnitude of dose change. So we can do it by measure the drug concentration before a dose change and after achievement of the steady state at a new dose. So it's particularly useful for anti-epileptic drugs showing a dose-dependent pharmacokinetics, such as phenoltoin and valproate. So number four, when there's a suspected toxicity. So taking the drug level can help to confirm the diagnosis of AED toxicity in patients with suspected toxic symptoms, or when toxicity is difficult to assess clinically, such as in children or patients with intellectual disability. So number five, when there's uncontrolled seizures despite an apparently adequate dose. So it may be helpful to identify the potential causes of therapeutic failure, such as poor compliance or low drug level due to poor absorption, fast metabolism, or drug interactions. Number six is a potential change in steady state. For example, when there is a change in formulation, like from immediate release to sustained release formulation, because the half-life would be different for the drug, or switch from branded to generic formulation, or from one generic to another generic formulation. So number seven is when there's an expected pharmacokinetic variability. I think this is very important to know that in children, there's a higher drug clearance, which decreases gradually throughout childhood. And for pregnancy, most with drug concentration reduced during pregnancy because the half-life would be much shorter. The elimination is much bigger, and return to pre-pregnant concentration within the first month or two after delivery. Or in liver or renal diseases, because that would affect the absorption, distribution, elimination, and protein binding of the AEDs, or in post-surgery state, or when there is drug-drug interaction. So number eight is when there is an unexpected change in clinical response. So it helped to identify the cause of the change. And number nine, when there's a suspected for poor compliance. So taking the drug level may help you to identify a recent non-compliance, but this cannot tell a long-term compliance or variable compliance, because the blood result can only reflect the recent compliance of the patient. So next, I will talk about some characteristics of some commonly used anti-epileptic drug. So I will talk about carbamazepine, phenobarbital, phenoltoin, and valproate, because I think these four drugs the drug level is usually available in most of the hospitals, and we have to be we have to be aware of the special characteristics of this drug, so we understand what are we actually interpreting when we look at the lab result. So first, for carbamazepine, there is a special properties of auto-induction. That means the clearance increased threefold within weeks of starting therapy. And second is there's variable dose to plasma concentration relationship. Also, carbamazepine is a potent enzyme inducer, so beware of the drug-drug interaction. And for phenobarbital, it has a long half-life, and it also has a variable dose to plasma concentration relationship, and it is a potent enzyme inducer, so also be aware of the drug-drug interaction. For phenyltoin, it has a narrow therapeutic range. That means you need a fine balance between the efficacy and dose-related side effect. So very often we need to obtain the drug level when the patient is using this drug. And it is highly protein-bound, 90% protein-bound. And it has a non-linear pharmacokinetics because it had a satuable elimination process. So still remember the zero order kinetics, yes. And it also a potent enzyme inducer, so be aware of drug-drug interaction. And it also has a variable dose to plasma concentration relationship. And for valproate, it's also highly protein-bound, 90% protein-bound, also has a non-linear pharmacokinetics because it has a satuable protein binding capacity. This is a enzyme inhibitor, so also be aware of drug-drug interaction, particularly when it is used together with lamotrigine. And also it has a variable dose to plasma concentration relationship. So this is my last slide. So I would like to conclude my talk by sharing with you the 10 golden rules concerning the use of therapeutic drug monitoring in antiepileptic drug. So this is actually suggested by the ILAE Subcommission on Therapeutic Strategies in year 2008. So number one, the application of therapeutic drug monitoring requires adequate knowledge of the specific pharmacokinetic and pharmacodynamic properties of the antiepileptic drug to be monitored. Number two, ensure that the laboratory has adequate measures for quality control. Number three, request the measurement of serum AED concentration only when there is a clear clinical questions. Number four, except for situation requiring immediate action, such as suspected toxicity or drug overdose, serum AED concentration should be determined at the steady state. Number five, sampling time should be standardized, particularly for AED with short half-life. That means those with half-life less than 12 hours. So under most circumstances, that would be a sample taken immediately before the next dose. That means a trough level. Number six, interpretation of serum AED concentration must take into account the interval since the last dose intake and the expected pharmacokinetic profile of the AED being monitored. Number seven, be aware that reference range of AED concentration have solely a probabilistic value and that many patients may require concentration below or above these ranges. So make sure that the patient is also informed about the limitation of the reference ranges. Number eight, when interpreting serum AED concentration, consider situation which may alter the relationship between serum AED concentration and the clinical response, such as old age, type, severity of epilepsy, clinical conditions resulting in altered serum protein binding, presence of pharmacologically active metabolites, or possibility of pharmacodynamic interaction with concurrently administered drugs. Number nine, consider the possibility of applying the individual therapeutic concentration concept. And number 10, which I think is most important, treat the patient, not the serum concentration. Never make clinical decision on the basis of drug concentration alone. Take into account information on patient history, clinical signs and symptoms, and any relevant additional laboratory information. So here are my references. And thank you very much for your attention. And I would like to thank Dr. Eric Yao for his invaluable advice for my sharing today. Thank you.